Hey everyone, welcome to my channel. My name is Beth. If you are a newly graduated or about to graduate, family nurse practitioner student, prepping for your boards, this review will help reinforce the core neuro concepts that will likely pop up on your boards. So a little bit about me before we get started. I have been a nurse for almost 10 years. I became a nurse practitioner about a year and a half ago, so I did take my boards fairly recently. I've worked in primary care and more recently in the urgent care setting. All right, so let's get started. Like the NCLEX, a key component of your FNP exam is your ability to recognize signs and symptoms associated with conditions that pose a risk of serious morbidity or mortality for patients. With this in mind, we'll begin our neurology review with a detailed discussion of headache danger signals. The first one is the thunderclap headache. This is a headache that is very severe and reaches maximum intensity in 1 minute or less. Also, if a patient comes in and complains of having the worst headache of their life. A new onset headache in patients 50 years or older. Sudden onset headache after coughing, exertion, sex, or straining. This may indicate an aneurysm. Sudden change in level of consciousness. Focal neurological signs including ipsilateral pupils, which is unequal pupil size, swallowing difficulties, aphasia, acute vision loss, visual field deficits, etc. A headache accompanied by papilledema, which indicates increased intracranial pressure. You want to make sure you are ruling out subarachnoid hemorrhage, subdural hemorrhages, arterial venous malformations or leaking aneurysms, bacterial meningitis, increased intracranial pressure, brain abscesses, or brain tumors. All right, next, let's talk about types of headaches. First headache we'll talk about is the tension headache. This is a headache that is tight in quality, intense around the neck or back of the head. There's no focal neurological changes with this headache. The main treatment for this is going to be over-the-counter analgesics such as Tylenol or Motrin. Stress-relieving measures like relaxation and massage therapy are also helpful. Migraine headaches, they are one-sided throbbing headaches that occur episodically. Focal deficits may precede or accompany the migraine. Visual disturbances are common. This would include stars, sparks, zigzags of light. Photophobia and phonophobia may also occur. Patients will come in often looking ill. Treatment for this, again, early use of NSAIDs may help significantly. Also, trigger avoidance, such as avoiding tyramine foods, relaxation and stress management. Other medications that are helpful in the acute setting, such as urgent care or ED, would be Reglan or triptans for abortive agents. And lastly, we'll talk about the cluster headache. This is very common in middle-aged men. This is a severe unilateral paraorbital pain that occurs daily or for weeks. It is common for the patient to have one-sided nasal congestion, rhinorrhea, and eye redness. Sometimes these headaches are precipitated by alcohol consumption. Treatment for cluster headaches includes 100% oxygen, sumatriptan 6 milligrams subcutaneously, and also important to note that suicide is more common in patients that have cluster headaches. Now we're going to move on to talk about seizures. There are a few different kinds of seizures. They're divided into focal seizures and then generalized seizures. So a focal seizure is a simple parietal seizure or a complex parietal. So simple parietal seizures, there's no loss of consciousness. They last less than 1 minute. They will start in a single muscle group and then spread to an entire one side of the body. Paresthesias, flashing lights, and hallucinations may occur. A complex parietal is a simple parietal seizure followed by impaired level of consciousness. The other category is going to be your generalized seizures. So this includes absence and tonic-clonic. An absence seizure, which is also called a petit mal, is when a patient has sudden loss of motor function and a blank stare. These are often discovered during childhood or adolescence. Tonic-clonic or grand mal seizures, these are tonic contractions and involuntary muscle contractions, loss of consciousness. They can last 2 to 5 minutes and a post-ictal stage will follow. Status epilepticus is a seizure lasting more than 5 minutes or having more than one seizure within 5 minutes. This is considered a medical emergency and is life-threatening. For seizure management, you want to get a CT of the head for all new onset seizures. EEGs are helpful. You want to protect the patient's airway, and then giving benzodiazepines like Ativan are helpful during an acute seizure. Next, we'll talk about Bell's palsy and trigeminal neuralgia. Bell's palsy is characterized by the sudden onset one-sided facial weakness. This is caused by inflammation of the facial nerve, cranial nerve 7. Patients are unable to wrinkle their forehead. If they can wrinkle their forehead, this is more distinctive of a stroke. So treatment is going to be early treatment with high-dose glucocorticoids, preferably within 3 days of onset. It's very important to provide eye protection for the patients, as a major complication is corneal ulceration. Trigeminal neuralgia is characterized by unilateral facial pain that follows one of the branches of the trigeminal nerve. This is triggered by chewing, cold foods or air, and also touch. First-line treatment is high doses of anticonvulsants like carbamazepine. You should do an MRI or a CT to rule out a tumor or an artery pressing on the nerve. All right, strokes and transient ischemic attacks. A transient ischemic attack is a temporary blockage of blood flow to the brain that lasts for a short time. This usually is less than 24 hours. Symptoms are similar to a stroke but resolve within a few hours. A stroke occurs when a blood clot cuts off blood flow to part of the brain for an extended period of time, causing tissue damage and death. So findings: ipsilateral monocular blindness. This is going to be blindness in one eye. Homonymous hemaniopia, which is vision loss in the same half of the visual field in both eyes. Impaired speech, contralateral arm, leg, or face motor impairment. A CT needs to be done to determine if it's ischemic or hemorrhagic. This will change the plan of care for the patient. Treatment for ischemic, you definitely want to give the patient aspirin, Plavix. You want to control for hypertension, and sometimes a carotid endarterectomy may be indicated. Here are some other important things to know about stroke that may be on your exam. Cardio events like atrial fibrillation, myocardial infarction, endocarditis, and valve disease increase risk for stroke. Also, atherosclerosis, arterial occlusions, and emboli will increase risk for stroke as well. This is very important. 1/3 of patients with a transient ischemic attack will have an ischemic stroke within 5 years. And below, you're going to see the BFAST assessment tool, which is very helpful in identifying a stroke quickly and getting patient the right care as soon as possible. All right, let's talk about multiple sclerosis and myasthenia gravis. In multiple sclerosis, antibodies attack the myelin sheath, causing demyelination. It is more common in women between the ages of 15 and 45. Multiple sclerosis has an affinity to affect the optic nerves, the spinal cord, brainstem, cerebellum, and white matter. It is relapsing and remitting disease, and it is also progressive. So symptoms will include episodes of visual loss, double vision, nystagmus, vertigo and balance problems, foot drop, one-sided facial paresthesia, bowel dysfunction, and urinary incontinence. Patients will often report being clumsy. Lhermitte sign may occur, which is an electric shock down the back with neck flexion. MRI is used for diagnosis. Patients may also have an elevated CSF IgG. As far as treatment goes, there is no treatment that can prevent the progression of multiple sclerosis. Steroids can be used for acute phases, and it is important to give the patient a neurology referral. For myasthenia gravis, this is caused by autoantibodies binding to the acetylcholine receptors. It is characterized by fluctuating weakness of commonly used voluntary muscles. Symptoms will often worsen after activity. Patients will show ptosis and have swallowing difficulties. Respiratory compromise and aspiration pneumonia are complications. Diagnosis can be done with acetylcholine receptor antibodies detected. Treatment, neural referral is indicated. Pyridostigmine and neostigmine can be used during acute phases to help dampen the severity of the flare-up. Immunosuppressives may also be used. All right, so with multiple sclerosis and myasthenia gravis, they can often present with overlapping symptoms, and this makes it easy to confuse the two. So for exam preparation, I recommend prioritizing understanding their differentiating features. For example, multiple sclerosis, remember demyelination, relapsing and progressive patterns. Patients will present as clumsy. They may have urinary urgency or hesitancy. Diagnosis is done with MRI and there is no treatment, only steroids that can be used to help manage symptoms during acute phases. In myasthenia gravis, remember autoantibodies binding to the ACTH receptors, fluctuating weakness. Symptoms are worse after activity, ptosis and dysphagia, and complications of respiratory compromise and aspiration pneumonia. Remember, diagnosis can be made by checking for serum elevation of ACTH receptor antibodies. Remember, pyridostigmine or neostigmine can be used during acute exacerbations to help lessen the exacerbation. Hopefully this will help. Okay, let's go over meningitis real quick. So some key characteristics of meningitis are Kernig's and Brudzinski's sign, and these indicate meningeal irritation, also nuchal rigidity or neck stiffness. Petechiae in the axilla, flanks, wrists, and ankles may be present. Patients will have symptoms of fever, headache, altered level of consciousness. Bacterial meningitis is considered a medical emergency and requires quick recognition. Viral meningitis can be treated with antivirals like acyclovir or valcyclovir. It is often caused by HSV or varicella. And lastly, S. pneumonia is the most common pathogen, and this is considered a reportable disease. Giant cell arteritis or temporal arteritis is not very common, but it may be on your exam because it can lead to permanent blindness if not recognized. So the findings with giant cell arteritis is going to be unilateral headache with tenderness along the scalp. Patients will have jaw pain that is relieved by chewing. It is important to note that the temporal artery will usually be normal upon exam. So labs, patients may have an elevated ESR. This, if suspected, it is an immediate referral to emergency department. Gold standard for diagnosis is going to be the temporal biopsy, which is often not available in outpatient settings, so it is important to send them directly to ED. Treatment for this is going to be high dose steroids, and like I said earlier, permanent blindness can occur without treatment. Because dementia is common among our older patients, it will very likely show up on your exam. So dementia will present as a gradual progressive decline of intellectual function. It's common or most common in patients older than 60. Alzheimer's is the most common cause which may show up in your exam. So it's important to know that depression and delirium may coexist with dementia, but also you should rule out delirium or other mental disorders before making a diagnosis. So when it comes to diagnosing dementia, Mini-Cog can be performed in any patient that you suspect cognitive impairment. If the patient fails, further testing is warranted. So this would include your mini mental state exam or the Montreal Cognitive Assessment. The mini mental state exam a score below 24 is abnormal. You do need to know that this score is abnormal and indicates cognitive impairment and also suspicion for dementia. Your licensure exam will likely not require you to know specific details about the mini mental state exam. However, I would review the components of the assessment. If you've already taken the exam and had a different experience, if they did go into detail, please let me know and we can go into further detail in another later video. Blood work should be performed on these patients. This would include a CBC, a CMP, a TSH, and also a vitamin B12. CT scan should be performed to rule out any brain disorders such as tumors or hematomas. Treatment, first-line treatment is going to be levodopa immediate release. Okay, let's talk about Parkinson's. So, cardinal signs of Parkinson's are going to be tremor, rigidity, bradykinesia, which is slow movement. Myerson's sign may also be seen, which is the sustained blink reflex with repetitive tapping over the nose bridge. It's also called the glabellar reflex. So, treatment is going to be symptomatic with levodopa, carbidopa, which is first line. And with these patients, dementia will usually develop. All right, and real quick, we'll go over essential tremor. So this is a postural tremor of the hands, head, or voice, and there are no other abnormal findings other than the tremor. It usually happens with action and is not present at rest. Alcohol can temporarily improve the tremor. Treatment is not usually indicated. It is a benign condition. However, if it is bothersome for the patient, 60 to 240 milligrams of propranolol in divided doses may help. Carpal tunnel syndrome. So this is going to be pain, burning, numbness, and tingling in the second, third, and half of the fourth digit of the hand. It is more bothersome at night, and it is a result of repetitive overuse of the hand. Diagnosis can be made with simple assessment with a positive Tinel's sign or a positive Phelan sign. Treatment includes reducing use of the wrist, splinting at night for up to 3 months, NSAIDs, and also injecting corticosteroids directly into the area. Wernicke-Korsakoff syndromes. This is confusion, ataxia, and nystagmus, eventually leading to lateral rectus muscle weakness and conjugate gaze palsy. So conjugate gaze palsy is when both eyes are unable to move together normally. It is caused by vitamin B1 or thiamine deficiency, usually from chronic alcohol use. Treatment is high-dose IV thiamine. If caught early, if caught too late, this can cause permanent brain damage. That concludes the neuro portion for board reviews. Thank you so much for sticking it out to the end. I greatly appreciate it. Hope you found the information useful. I hope it boosts your confidence going into your exams. And if you have any questions, comments, any suggestions, please leave it in the comments below. Also, like and subscribe if this was useful to you. Hit the notification bell. I do plan on coming out with some more review videos in the very near future, and this will allow you to know right when they come out. So again, good luck in your exam, and thank you so much.